I want to welcome everybody. Thank you for being here. We're going to get started because I think we're probably going to need all the time we can get for this important topic. My name is Jim Merrill. Jane McCabe, where is she? There she is. Stand up, please. She and I will be facilitating this meeting. Let's see. And I want to tell everybody that this town hall group is interested in working towards a collective process that includes all points of view. So thank you for being here and getting involved in this democratic process. So this is, if you have important topics that you want to see explored in this format, please let some of the people who are involved in this planning process know. If you could all stand up, that's Jane McCabe, myself, Jack Bauman, and where did Patricia? Over there, April Trudell, and Carol Hughes over there. Contact any one of those people if you would like to plan some kind of topic for exploration in this meeting. The topic for today is mental health services in Mendocino County. What do we have? What do we need? And how do we get there? We want to try to proceed and see what we can envision. What do we have? And how do we get there in a way that moves forward, not laying blame in the past, but just moving forward. And that's what we're going to try to focus on today. So try and keep your questions and comments focused. And what we're going to do here is have the panel presentation. They're going to have up to about 10 minutes each. And then we'll open it to questions. So I'm going to turn it over to the panel and start with Wynn. And you're going to give us an overview of... Good afternoon. Wynn Novotny, Executive Director of Manzanita Services. Thank you.
Thank you. Manzanita Services is a nonprofit. We started in 2008. We're a peer support nonprofit, and we actually originally took over for a healing cooperative, which was the nonprofit prior to us under the umbrella of the Methodist Church in Ukiah. They got the first peer support money that came through the Mental Health Services Act, which was voted on by the California voters in 2004. And this is client-centered recovery money that came in to, in quotes, transform the system. So the first round of money that came in at that time was community supports and services, and a third of that went to growing up peer support, recovery, and wellness centers. At that time, there was a wellness center beginning in Ukiah, and then up here in Willits, there was Healing Hearts, and in Fort Bragg, there was a small support group called Heart to Heart. And at that time, Manzanita wasn't in existence, but a healing cooperative reached out, and I was involved at that time on the mental health board, which is now the behavioral health board. And I traveled back and forth and worked with the director at that time, Noel O'Neill, to try to really bring those peer support efforts together and coordinate them and grow them up. So I became director in 2011, and prior to that, we had what I would say was the model that we wanted to really move forward here in Willits. We had rented, for those of you who knew us, we had rented the Victorian, which was across from the park. We had an art program and peer support topics and education and a warm line, and we were really happy with where we were headed in Willits. Our first director was a Willits resident, and we just, really had a lot of hope. And unfortunately, at the time, and I believe that was about 2009, we were unfunded for Willits. And so we were in a situation where we held on to that center for 6 months, kind of piecing together private donations, et cetera, because we really didn't want to close the Willits Center. We got a lot of private donations to try to keep that center open. When it closed, we moved to the Whisk Center, and the county gave us that room at the Whisk Center for free so that we wouldn't just fold. So we were at the Whisk Center, and then we looked in this community for an affordable rental, and we ended up at where we are now, which is we're renting from the Willits Methodist Church. Up here, we went from a 5-day program to a 3-day program. So right now, we're Monday, Wednesday, and Friday officially. And we have one special group on Thursdays that's run by a former staff member who now contracts with us. She does this really incredible poetry group where people collectively create poetry for their expression and wellness, and she does that on Thursdays from 12 to 2. So that's what we have in Willits, and in Ukiah we have Monday through Friday. So we have multiple parts of our program. We used to have just the wellness recovery part of our program, which was a lot of education, self-help education, wellness recovery action planning, anger management. We get a lot of people who need that, both they know they need it, or the courts ask them to come, or there's multiple ways that people walk through the door. We teach life skills, which is a curriculum that people need if they're getting shelter plus care vouchers for their housing. We have specialty art groups. I'm looking at my staff member. What else? We have peer support topics, education, advocacy, volunteerism. So that's the wellness center part. In 2013, we became Medi-Cal certified in Ukiah when the county outsourced services, and we took on adult care management for originally 21 and above that first year. And then when the contracts changed and the Ortner management took 25 and older, and Redwood Quality Management expanded to include the transition age youth, we had contracts with both, and we still do. We also have contracts with Hillside Clinic, 2 different ones, which actually our Hillside Clinic contract in Ukiah was one of the first contracts outside of MHSA that we had, which was to do outreach to the homeless who have multiple mental health issues, homelessness, substance use issues, and to really get them to primary care so that we can have a whole health approach. The second contract we have with Hillside Clinic is a grant that came in from Partnership Health Plan to look, it's called Intensive Outpatient Case Management, and it's really looking at those of our Medi-Cal population that have incredible challenges with their health. They have a behavioral health issue, most often an alcohol and drug issue, and then many times 2 or 3 other chronic illnesses. So this came kind of, for those of you historically, out of the chronic user system of care, which Manzanita was not a part of directly, but supported that effort between the partners, Hillside Clinic and McCavan and Ford Street and the hospital, UVMC. And then we really helped. We had a lot of the same clients, who really needed that extra support. I think one of the things I really want to address is, what is peer support? What is peer support, and why are we a peer support program? And why do we continue to remain a peer support program? Peer support is that you have lived experience plus education in schooling and in motivational interviewing, and there's a lot of different topics I could go on and on about the different education that my staff has, because there's a lot of misnomers about peer support. there's been a lot of stigma, along with behavioral health stigma. There's a lot of stigma about peers staffing programs, that somehow if you have lived experience that you don't have education. I have MFTs, MFT interns, people with AOD licenses, mental health rehabilitation specialists. We have people who've graduated in art therapy. I have someone on my team in Ukiah who's the director of Yoga Mendocino, and she also is a care manager for us and an MFT intern. We have a lot of education and lived experience. Either we ourselves have mental health issues or we have loved ones in our families that have mental health issues. So this is something that is near and dear to my heart and to us. You know, this is now my commercial for us. I really believe in us. The way we approach caring and supporting people, how we empower them, the recovery education we give them so that they can maintain their health and well-being, the socialization so that they're around a lot of other people who are also pursuing, finding ways to stabilize if they're symptomatic, getting the help they need, living a life where they make choices that don't put them at further risk. So establishing friends and a social community that is supportive of those efforts, where you can come in on a bad day and someone's going to be there for you and you don't have to have an appointment, has been really effective in preventing further issues and giving hope. We do outreach. We've been fortunate enough to get support through community members, through the county, through the sheriff's office to have a van. And we get people to their behavioral health appointments at the same time that we really do approach the way we work to not. We start out for supported independence, and we're really looking at empowering people to independence. We're not dedicated to codependence. We're really dedicated to independence. So it's difficult at times when you have services, and one of my lines when our van was available is, "We are not a taxi service." However, we're really responsive to the individual. We take them one-on-one and really see what are the barriers to their getting consistency in their life, meaningful activities, work. We have a volunteer program that goes from volunteering to Voc Rehab for those who want to go that direction. We partnered with Buckaloo from Marin, and they're in Marin, Sonoma County, Napa, and they stepped into Ukiah. They got vendorized through Voc Rehab. They didn't have a place to land, and I was kind of desperate I had a young man who said to me, "I really want to work, but I don't feel safe anywhere, and I want to be here in Manzanita." And he motivated me to reach out and try to find a way to get Voc Rehab inside of Manzanita, because we really didn't have the capacity to do it ourselves. So I called them and invited them in, and they were grateful to have a place to land, and so we gave them an office and a place where they could train, and then we encouraged those who were ready to go through. They had to go through Voc Rehab, but they could get assigned back to Buckaloo at Manzanita, and that created a safe environment, and we had graduates who then went into volunteering, and we have a few of our clients that now have gone on to be hired. So it's we're little. I mean, I say that, and some people have said to me recently, "You're not that little." We care for a lot of people. We have, I don't know what the statistics are this year. I haven't accumulated them, but I'm going to be conservative. We had about 375 clients that we served about 10,000 times, so 10,000 touches. Of those, We care manage about 40 through specialty mental health, and then the others come through the wellness center or these other forms of care management that I mentioned earlier. I used to not like when I kept hearing all the time there's capacity, from many, many parts of our community that there are capacity issues to respond to the needs of behavioral health. And yet, I can say it for myself, is we have capacity issues. We'd like to do more and be involved further in developing other parts of what's needed in this county for behavioral health, which I'm sure we'll get to. We have a small contract. I'm very happy it's on the, you can find it, but currently we have a $350,000 contract to do everything I just said for adults. We have another small contract with Redwood and about $30,000 in contracts other than the $350,000. So that we do all of that in Willits and Ukiah on about $400,000. That's the simple version of it. Thank you.
Thank you. I want to introduce Chandra Gonzalez, Program Manager for Redwood Quality Management. Thank you, Chandra.
Hello. So I'm Chandra Gonzalez, and I am here representing Redwood Quality Management Company, which is the ASO, or Administrative Service Organization, that is contracted with the county to provide mental health services for youth and young adults age 0 to 25. There is a lot of back and forth between RCS and RQMC, so I'm going to just give a quick history there. When the county originally put out 2 RFP mental health services, RCS, Redwood Children's Services at the time, now Redwood Community Services, knew that that was something that they wanted to be a part of in looking at who else in the county could bring these services or keep these services going for youth versus having out-of-county providers come in and bid on that and see what happened to the system. So RCS met with Tapestry and Mendocino County Youth Project and the other children's providers and kind of all got in this plan. RCS responded to the RFP and thus said that they would create Redwood Quality Management Company. That would be a management company that oversaw all of the subcontracts and the ASO services. So they are linked and they are separate, and there are separate staff that only work for RQM, and there are some staff that share back and forth helping out with needs. So that said, in a brief nutshell, RQM has multiple subcontracts with providers here in the county. RCS, Tapestry, Mendocino County Youth Project, Manzanita, McCavan, and Hospitality are all of the Medi-Cal providers that are contracted here. We also have contracts through MHSA, which is the Mental Health Services Act, that include the Arbor Youth Resource Center, some monies to crisis. We have programs that serve Latinos, Covelo, Laytonville. We have Action Network down in Walla and Point Arena, and Anderson Valley Unified School District. I'm trying to rack my brain. And we will be getting some funding finally this year for Laytonville Family Resource Center. So we have a broad range of what's provided through Medi-Cal and MHSA. We also have Behavioral Health Court, which is wonderful. It was 11 o'clock court, now it's Behavioral Health Court, and soon coming Laura's Law. Well, it's here, but we have yet to have a Laura's Law client, so I say soon coming on our side. We do provide also the crisis response for youth and young adults under 25 through the Redwood Community Crisis Center, which I also manage. We have a 24/7 hotline. The county also has the access line, which every county has, that is currently answered by ICMS, and they route calls to us if they're in our age group, or we receive calls directly ourselves on our hotline. And we do the response to the emergency rooms, jail, juvenile hall. We also do, every now and then, depending on what our staffing is, pilot being mobile, and have responded to schools, hotel rooms, streets, the Arbor, wherever the crisis may be. And we all broker those hospitalizations if needed. We do the transports back into the community. For the clients we have that are conserved, on our side, we currently have 2. We were down to just 1, and then we had 1 new conservatorship last week, I believe. So now we do have 2. We arrange for those placements as needed out of county. We do the utilization review, calling and checking in with them, bring them back to the county for court as needed, and work with them to help get off the conservatorship. We did successfully bring 2 conserved clients that were in placement back to the county, where we were able to house them through Gibson House, which is a supported living environment. It is actually a house on Gibson, hence Gibson Street House. And they live there. They have 24/7 staffing and help integrate back into the community and show that, they don't need to be locked up out of county in a facility. They can come back here and be successful. So we've had good success with that. 2 youth there that have then gotten off their conservatorship. There's a lot, if you've seen in the paper recently, that Ortner has given notice on their contract. So we have said that we will be the transitional ASO, helping the county out with that as needed for pieces that, whether they are going to take them back or pieces that we will then take back to assist in helping with the transition. So some of that is bound to change in terms of what I'm saying and what we do with the 0 to 25. But we do have a solid foundation going with providers in the community that we're very happy about. We currently, now I'm looking at when to see, look at all the people. We currently do also have a contract with Hillside Mendocino Community Health Clinic, and we use them for the services of Dr. Timmy as our psychiatrist and medical director. So she is available to us and our crisis team 24/7, which is nice, to consult on crisis calls as needed or recension of holds, that type of thing. She's also available to consult with ER doctors and nurses at the clinics, which she has and does on their request. And it's nice because we'll get a call in crisis and we can call her up right away and say, hey, it's this client, or she changes a med, and we can get to her over the weekend and figure out what's going on. So that has been a wonderful collaboration with Hillside, and we're very happy that they allowed us to enter into that. I think that's probably it in a nutshell. I won't keep talking just because I haven't talked as long as Wind, but I'm sure there will be more.
There'll be questions
there in the
for you.
questions.
Yeah. Thank you, Chandra. Appreciate that very much. Tom.
Good afternoon. I'm Tom Allman. I'm sheriff, and let me tell you, think about where we are right now. It's a Sunday afternoon. We have the worst weather storm of the season, and 35 people have found mental health to be such an important topic that we're sitting around to discuss how do we improve it. And I can't think of anything more exciting, honestly, than right now to have people wanting to be here. Nobody's getting paid. Everybody's here because we want to be here, and that's exciting. So you have to ask, if you don't mind me telling you what you should be asking, why would a sheriff be so involved and interested in mental health? And that's a very good question. That's a great question. When your house is on fire, you call the fire department. When you have a bad guy or a burglary, you call the law enforcement. If there's a person here who believes that if there's a family member who's having a psychotic episode and you call 911 and you're going to get a mental health professional responding to the house or the business, let me dash your dreams right now and tell you that law enforcement will most likely be the one responding to your house. Now think of this. We train these law enforcement officers for 6 months. That's how long the police academy is. And the police academies train them that, they need to defend themselves, and they have all these implements of destruction on our belts, and now at 2 o'clock in the morning, they're going to go deal with someone who's having a psychotic episode. And we may be talking about a 21-year-old deputy sheriff whose life experiences are limited, at best they're limited. And now we're putting our trust, and I have all the trust in the world in my law enforcement officers. Don't get me wrong, I trust my deputies. But it's like sending a plumber to a fire. Why are we doing this? Somewhere in the next week, let me guarantee you that there will be some place in the nation where a law enforcement officer will respond to a mental health crisis, and it will end in a disaster. Somebody's going to get killed. There's going to be rallies around the police department saying, why did you do this? And that's a fair question, but that's not my question. My question is, why are we sending law enforcement to psychotic episodes? Well, what are we doing? And I'm not saying that law enforcement won't respond to an act of violence, or if somebody has a gun and says they're going to kill themselves. Believe me, we'll take that. But when somebody's depressed and somebody is needing help right now, what they get, if law enforcement responds, is they get a guy with a gun and a badge, and they get put in the back of a police car, they get taken to the emergency room, they get evaluated, they get transported either to Yuba County or to Solano County for the 72-hour crisis, and we're saying that's the proper treatment. And that's why the sheriff's involved, because that's not the proper treatment. In law enforcement, and in the jail, I certainly run the jail, and the jail average, and I'm not proud of this, our jail is built for 304 people. The statewide average is 20% of all county inmates are mentally ill, and that could go anywhere for being treated as simple as counseling, all the way to doing the lithium shuffle. You know, there's a whole gamut of those people who have broken some law, and the judicial system has deemed it important for them to stay in jail, but now that responsibility falls upon law enforcement to keep a person who's mentally ill. What could possibly go wrong? Are we really and truly doing this the right way? Are we caring for these individuals? Because a jail is not a treatment facility for mental illness. A jail is a correctional facility. And we need to get to the point where, once again, our county has a place where people can receive treatment and they're not going to be in county jail. When suicides occur in the jail, I'm sure people say, why did the sheriff's office allow this suicide to occur? But now think of this. You know, when we have 20% of our population who's in a small 8x10 cell and are mentally ill, that person's decompensating. And I get it, the same as you get it, and we have to get to a point where we have a better place for not only just the identification of mental illness, but the true diagnosis and the treatment. And we're getting there by talking on a Sunday afternoon with 35 people saying, how are we going to get there? We're very lucky to have had a good psychiatrist in our county, Doug Rosoff. Doug Rosoff was a leader. Doug Rosoff worked in the jail. He worked with the veterans. He worked with mental health. He worked with Hillside Clinic. He worked with everybody. And then, unfortunately, several years ago, he was tragically killed in a bicycle accident. We haven't got to the point of replacing him, even though the county has flown the position at a very high rate of salary for 3 years now. And when I say high rate of salary, we're talking around the area of $250,000 a year, and it has not been filled yet, of trying to attract a person to our county to provide these services. Wow. Kids, if you're watching this on TV, go to college, become a psychiatrist, okay, and then come back to Mendocino County. So the three questions behind us: what do we have, what do we need, and how do we get there? What do we have? We have the basics. I'm not going to criticize Ortner. I'm not going to, and I haven't done that in my talks to the Board of Supervisors. What do we have is, I would answer by saying not enough, but we certainly have the response to get someone, if they are willing to go to the emergency room, either against their will or voluntarily, we'll get them to the emergency room. They'll be hopefully evaluated. They'll be taken to, as I said, Yuba County or Solano County. We are woefully lacking in what we call crisis residential. In other words, a transition after a 72-hour locked facility, getting them into a facility where it's not a locked facility, but they can come and go, but they're transitioning. And I want to make sure that we have an understanding of the chemical imbalance. We've all heard that, dual diagnosis, chemical imbalance. We've all heard these things going around, and I don't believe that there's a doctor in the house, is there? A chemical imbalance is something that we have to think about. If your transmission is broken and is fixed, you take it to a transmission guy and he'll fix your transmission and you can drive away. Well, when there's a mental health evaluation, they don't say, all right, you know, your appointment's at 9:30 and we're going to diagnose you, and by 10:30 you're going to have your medication and you're going to be fixed by noon. It might take 5 years for the medication to be tried and at this dosage, and make sure it's not reacting to this dosage, because we're all different. And the chemicals that they have out there sometimes work great and sometimes work poorly and we shouldn't even be put into the body. But that we have to get to the point of understanding that it's not as easy as treating a broken arm. The mental health treatment and diagnosis could be a multi-year facility. And there's family members in here who understand that. In 2005, my brother committed suicide in Humboldt County, and my mother is 85 years old, and that's her every hour of every day she's awake, alive, she thinks of my brother Mike. And we have to get to that point where we can be patient and trust the doctors to get there. What do we need? There's 4 parts of a mental health continuum that I'd like to talk about. And I'm talking about what do we need in Mendocino County, because when we send our citizens to Yuba County or Solano County, there's a big bell going off here. We send lots of money to Yuba County and to Solano County. I mean, in the millions of dollars for the treatment of these individuals. So let's talk about these 4 pieces. We need a 72-hour locked facility. We need a facility where people can go and they can just decompress amongst professionals. The professionals are watching them, making sure they're not going to harm themselves, and for 72 hours they're going to be evaluated. And then we need that, as I was discussing earlier, that crisis residential to move them into this area where they can have interactions with their family, they can get their counseling, they can start their medication evaluations and so forth. We certainly need a drop-in clinic, and kudos to Manzanita, because Manzanita is a great example of, I only wish government could stretch a dollar like Manzanita, but they're a great example of trying to make it work and having success. So we need a drop-in clinic, and what a drop-in clinic would do would be outpatient. So whether it's to provide medication, provide counseling, to sit in a corner and stare out the window, to make a sandwich, I don't care, but something that allows a quality of life for that individual to improve. And the last we need is the AOD, because if we're not talking alcohol and other drugs and addictions that we have that are hand in hand with mental illness, then that's we're missing out. We have to alcohol and other drugs, and that would work for the veterans also. So those 4 pieces are very important for something to happen in Mendocino County, because we're a pretty smart county. You know, our county's big, 3,509 square miles. We only have 89,000 citizens. But the brain power in that group of citizens, I've come to truly respect, because we can solve our problems. And here we have this situation of Ortner, and Ortner, let me tell you, and there's been a lot of bad things said about Ortner, but there's been several situations where I've called Ortner to say, on this case, we need help right now, and every one of those, they've taken care of that person. But it shouldn't take the sheriff calling the president of Ortner to say, take care of this person now. It should be taken care of at the lowest level possible, to where there's no ripples in the pond. We take care of our people. So I do appreciate some of the streamlining that Ortner has done, but I believe that we'll see with the transition going to Redwood Quality right now, that we're going to see the streamlining continue, and we're going to see local people taking care of local problems, because we're kind of smart like that, and that money is not going to go to different counties. There may be times that money has to go to different counties, because right now we don't have those 72-hour locked facilities. Somehow in this afternoon, I certainly would like to discuss the initiative that myself and 12 other people are working very hard. It'll be presented to the Board of Supervisors this Tuesday. Mr. Woodhouse, Board of Supervisors Tuesday. But how do we get there? You know, we've had many social problems coming up in Mendocino County. Probably the M word is the biggest, okay? And how do we get to resolution in marijuana? By keep talking about it, by listening and following good advice, realizing when we make a mistake and step back from a mistake and try something else, and that's how we get to a solution. And so we're getting close, and what happened this last week with Ortner, listen, I believe it's going to be a step forward, but they have done some good things for our county. But we're learning. If we've touched a hot stove once, we're not going to touch a hot stove twice. We're going to make a forward step. So thank you.
Thank you, Tom. Appreciate that. Do you have cards, Jane? Okay. So we're going to take these cards and read these cards first, and then after that we'll open it up to general questions and comments.
How are clients able to access treatment, and how often are they seen?
There would be a difference based on the age of the client currently. On our QM side of the up to 25-year-olds, there is a no wrong door for access. So I'll assume we're not talking about crisis for the moment, but just to access mental health services, anybody can put in a referral. The teacher can, the neighbor. I mean, really, any third-party referral could be put in either directly to RQM or to any one of the individual agencies that provides the service. And then they would take the referral and contact the youth, the young adult, family, make sure it's a viable referral, and then go ahead and schedule them to come in and have an assessment. Everybody should be getting an assessment within 14 days. It is our goal on the county, both on the youth, young adult, and adult side, that happens within 14 days of the referral. How long they would, or how often would they be seen? That is going to depend, I would say, on each individual person's need, what was on their treatment plan, what their diagnosis was, what it was they were getting treatment for, what their goals were that they had identified. So that will vary. On the crisis side of that, for us, we do have the 24/7 line. They can walk into one of the crisis centers, or we would get a call to go out to the ER. We would see them immediately if they walked in or we went to the ER. Otherwise, if it was something that was more of a pre-crisis, they didn't want it to get to that point, we would schedule to have them come in or to go out to them the following day or later that day if needed. And then we keep that case open for up to 60 days following the initial crisis. Whether it resulted in hospitalization or not, they're open for 60 days. We see them fairly frequently. It depends on the need. It is voluntary, so it would be how much they were available or how much they're wanting to come in. We've definitely had cases where they're coming in every single morning before school. They're doing a check-in with us. We're making a new safety plan, and then we're driving them to school and dropping them off. Or it could be phone check-ins during the week. It really varies client by client. But they all do stay open for 60 days. If they're needing support longer than that, they'll stay open longer than that. And it's really about then a referral back to either whoever was their primary provider in the beginning, Tapestry Youth Project, RCS, or private, and then if they don't have that already, putting that referral in, so making sure that we're crossing over. It is available in Willits. We do, for our follow-up services, we go out to the home, the school, the community. They don't need to come to us or go to the ER. So we do have what are called rehab specialists that will go out and do that. We see multiple youth in Willits. They'll go to Laytonville, Covelo. We'll send them anywhere where the youth is and goes to school. And then if it is something where they do also see our therapist in crisis, we'll have somebody will go out and pick them up, and we'll bring them down here to have therapy, and then we'll take them back home. So we do that transportation also.
Can I just follow up by one service people may not be aware of, and that's we're in the 15th month of a pilot program, so I hope the pilot program is going to be a permanent program of having a mobile, a two-person response to respond to people in the Covelo area, Round Valley area, and the South Coast, Point Arena, Molalla. An employee of mental health, an employee of the sheriff's office, a non-armed, non-peace officer team that what they do is they check in with people who used to be coming on the radar of law enforcement on a regular basis. And they just check in to say, how are you doing? Are you taking your meds? Do you have your meds? Have you eaten? Are you wearing clean clothes? Is your heat on? Whatever it is. And what law enforcement has found for the last 15 months is we're seeing this drastic decline in these responses for these people who were just, for lack of better words, being ignored. And we're really proud of where we're going. And the good news is that representative from Social Services has asked me if we'd be interested in participating in another team, so it would go to 2 different corners of the county. And the answer was a resounding yes. Of course, when can we start it? Because this is just a low-cost response that nobody knows about, and to get anybody referred to those people is just contacting mental health, or contacting the sheriff's office, and that's how we get involved.
Kind of piggyback on that, and then I will tell you how things are happening now, even though we're about to go into a transition. So outreach, that you have people who are shut in or they're isolated. I can't even say enough about how important that is. And, thank you for doing that. We outreach also, but we don't go to the far corners of this. When my son got sick, I was living at 10 miles up Bell Springs Road. And he was away at school, but he came back to be with us because he was really, really, really sick. And I can tell you, it is tough. In the beginning for me, there were moments where I couldn't leave him because he really needed me to be there all the time, and I didn't know how I was going to do it. Because it's a long ways just to get to Laytonville. So that's where I started in my journey, and I know how important outreach is. It can make the difference between making it or not making it. So for the adults 25 and older right now, if you're not open to the system and you want to, you're reaching in and you want services, you call the Access Center, which is ICMS, Integrated Care Management Solutions. They are the gateway in. We are an open door. Manzanita Inland is an open door, and Hospitality Center on the coast is an open door. So when, if you come through our door, we will walk you through and one by one see what you need, because sometimes it's many things. It could be that you get an assessment and you come into specialty mental health, but you may need 4 or 5 different referrals and things. Many people walk in with multiple needs all at once. So, we link and refer, and we will walk, and we do go with them if they want us to. We walk them through the access door, and they get assessed, and then they are referred for care management services if they meet medical necessity. So it's about intensity, duration, frequency. We refer to the clinics if they don't have primary care. I mean, we make lots of referrals and linkage through Manzanita, but for specialty mental health right now, for 25 and older, that first assessment goes through Access. We have the ability to do assessments inside of Manzanita. We didn't always. I mean, we got Medi-Cal certified and grew our team up over the last 2.5 years. So we do the follow-up assessments and the follow-up plans. So every 6 months, a treatment plan is updated, and every year their biopsychosocial is updated. We do those in-house with the people who are referred to us. I kind of want to do one last thing around the word treatment. Our experience, or I'm going to say my experience because I don't have my whole team here, but my experience is that there are a lot of people who come in and they ask for therapy in addition to a care manager, and depending on your caseload, depends on how often you're seen. In our agency, we have a small caseload. When we started with Medi-Cal certification, there was a grow up, learn this, and the promise of mentoring to learn how to do this. And Manzanita literally in the beginning took all of the referrals because ICMS was not Medi-Cal certified until November of 2013, and we were certified in September. So the first round of handoff from the county came to Manzanita. We went from, oh God, it's a good day today. We are not there. We went from 0 to 100 clients, and just were learning how to do this. We weren't learning how to care for people, but we were learning the Medi-Cal paperwork trail, which is quite something. I don't want to go there, but I got there, so now I have to get from there to here. Is in 2014, so 9 months later, I said, Manzanita we're really dedicated to quality care. We said we're going to limit our care loads. We can't carry a care load of people that makes it impossible for us to care. So we handed, and And the Ortner team was very responsive. I have to say, it took a few months of back and forth negotiation, but I said, look, we're going to explode or implode if we don't do this, because my team is teaching and doing outreach and housing and doing care management and wearing several hats, and it's new to them. So we limited our care load. And we see people weekly. Sometimes we see people daily, and are open, and it is exactly as Chandra said, it's what they need. There's duration. How often do they want to be seen? And our open door, they can walk in every day. But care management, we see them at our place in Ukiah or at their place, depending on what they want. We go to them or they come to us. And that's, formal care management with appointments and things.
Thank you. Any plans for a hospital or crisis center?
Please, Mr. Kata, please.
Grab that question.
So I've been working with a group that is going to be proposing a half-cent sales tax for 5 years, 60 months. And it is not for the staffing of mental health. It is to develop a brick and mortar location in this county where we will once again allow our people to be diagnosed and treated instead of sending them out of county. And so the first question people will say is, well, what about Old Howard Hospital? I understand that. It's a great question. And I think that that's a very good possibility. However, there are some building things we have to get over, as in earthquake and the OSHPOD and all the regulations that drive the definition of a hospital. And there's also a concern from the residents around Howard Hospital. Well, what do you mean you're going to turn this into a mental health facility? And I think that we can properly address those with locked doors and with fences and with cameras and door alarms and many things that we just need to wrap our heads around and come up with a solution. The initiative is hoping to raise money. I don't think that we can, at least our group, can commit to the Howard legacy, the Old Howard Hospital at this point, but maybe the county could. Listen, we're pushing this, and we are. You can only pass a tax initiative during a general election, so that's every other year, and here we are this year. So if we didn't do it this year, we'd have to wait 2 years, and we're not going to sit silently. We're going to push it. So we do need a hospital.
How much training do police officers have around dealing with mental illness at the Sheriff's Department?
That's a fair question. We certainly have more than what's required. What's required is in the police academy, and we have ongoing critical incident training. But the deputies are not a Swiss Army knife. You can't use them for everything, which our government has been used to using them for. If the road is closed, deputy, go clear the culvert to make sure it drains, and we can open the road. And you're also deputy coroners, and we have a death over here, and wait a minute, we have someone mentally ill over here, and we have a burglary over here. And what I'm saying is, we have training, but is it really what we want to focus on for our law enforcement officers? I'm saying that I don't want to overload a law enforcement officer by being responsible and then having something go bad, and someone says, why did it go bad? Well, because we're humans, not robots, and we need to make sure that we have the crisis training, but we're not psychiatrists, we're not doctors. We put the Band-Aid. When we transport someone who's mentally ill, it's our policy to handcuff the person for the safety of the deputy sheriff. Well, I think that we could all get a unanimous agreement. That's not the best care that you give someone who's mentally ill, but I don't want to put that deputy sheriff in a position where we're taking away his or her safety. We do have the training, and we've worked with NAMI, National Alliance on Mental Illness. Please, if you've never thought about joining any other organization in this county, look up NAMI. We have 2 chapters. We have an inland chapter and a coast chapter. We've worked with NAMI for crisis intervention training, so where we can get to the point where law enforcement and hopefully a non-law enforcement person can respond to crisis situations. That would be the perfect situation. But remember, law enforcement is 24/7, and at 2 o'clock in the morning, there may not be a non-law enforcement crisis intervener to ride along with our deputy sheriff. So we have some, we have more than what's legally necessary, but we don't have enough to perform the duties which are expected of us.
If you're going to join NAMI, I'm a member, join NAMI Mendocino.
Yeah, not national.
You can go on the national website and then say you're in Mendocino County, and that way it supports us locally. And they do everything they do for free. They give classes and family-to-family and peer-to-peer classes that are 10 and 14 weeks, and support groups and outreach to families. And
we now have a NAMI group that meets here on alternate Mondays
Yeah.
as well. It's at the back of the Methodist Church.
My mother's proud to be a
Monday
NAMI
noon.
mommy. That's what she calls herself.
It says, this question is talking about a local mental health facility. It said, it's a big commitment, but we need intense emergency acute care and day treatment, outpatient, and maybe we need to rethink Ortner's approach.
Well, I think we've covered that. You know, the four piece of mental illness, I mean, the four piece of providing solutions is I think that was covered in that question.
Mm-hmm.
You wrote the question, you don't think we covered it, let's go. Okay.
How can housing or shared housing be more addressed?
So housing is a tricky one because it is not entirely addressed within mental health and the ASOs, and it kind of is definitely a need and definitely a priority and kind of lives a little bit to the side. And that may just be on our QM side. I know there was housing that the county had, and Ortner had those slots to fill, so we weren't necessarily involved in that. We did, our QM purchased Gibson House and used that as a way to transition. And MHSA was funding Tay Wellness, where we have a department over on Washington Courts in Ukiah where we can house 16. We have 16 FSP slots for apartment housing for transitional age youth there. But it is rough because there is, you know, when we look at the ASOs and the county contracting out these beneficiaries, it's Medi-Cal. It's the people that have Mendocino County Medi-Cal. And we add in MHSA, which is another funding which kind of helps us serve everybody and fills the unserved, underserved in some of the remote areas and other places. And we have realignment dollars, and you know those go to certain things. But in the Kemper report, when it talks about different areas that we can address, I think housing is a good one to address. Initially, when the RFP went out, they said housing would be a separate RFP that came out at another time. And I know that there is currently MHSA groups going on right now for housing. I don't know exactly where the next one is, but there was just one in Wallala and Fort Bragg, and I want to say they're coming over to North County next. I want to Laytonville maybe. Laytonville last week. Okay, I knew it was coming soon, but they are going around. They did have some housing money through MHSA that they are looking, and I did put that out to RFP. Rural Housing Development, is it RHDC? Did receive that, and so now they're looking for buildings and different ways to utilize that money, and they have a survey going on. I would, of course, be great if I could give you the link to that survey off the top of my head, but
I think it's on the MHSA
it should be on the website that the county has for the Mental Health Services Act. But if you would like to be more involved about housing, I would find out when the next forum for that is that's happening, or definitely go online and take the survey. They talk about the dollars they have, the surveys, would you rather see one big facility or two facilities, or what they could do with the money. So that would be a great way to get involved there.
Mike, is that relates to this?
Yeah. How much housing do we need?
How many angels can sit on the end of a pen?
Well,
Yeah.
Well, there,
Speaking of housing and MHSA,
yes.
there is an effort going on with Senator Sandberg. I just spoke to him last week for about an hour, and most of you probably already know this, and it's not a overnight fix, even quick enough fix as a possible tax initiative, but they are strongly encouraging legislation that allows for MHSA dollars to be used to fund a bond that funds housing which is undisputedly one of the biggest issues for mental health, solving a lot of the problems. I mean, it's proven, no one can even dispute it. So there is a real effort going on. Who knows how long it's going to take. Steinberg's pretty quick at these things. I mean, obviously he's the champion of mental health, whatever you think about him or not. But there is a big effort that will utilize MHSA funds for that. Who knows when it's going to happen. Could be in 2 years, 5 years, but it's probably the largest effort right now financially to utilize what's already going on.
So I was just going to say, just on Friday I met with someone from Redwood, and we're trying to look at something that's we have no funding for, but you can't not get housing in place because people are at risk, and it doesn't help their behavioral health to be homeless. So whether we like it or not, we're trying to get creative about many different types of options, and hoping that if we can identify the properties that the cities are open to, and we can then go for funding where we already have identified the properties, because some of the funding, you're chasing your tail. You need the place to get the funding, but you can't get the place without the funding. So we're looking into some ways of getting many different types of housing, because different people's circumstance, some people cannot live with other people. So then we build these places where they're supposed to live with 6 or 8 other people who also have behavioral health issues. And it's tough on some, and it works for others. For others, they don't want to be alone, and for some, they need that independent apartment or that, studio apartment or one-bedroom apartment, and they need outreach and they need places to go. But for them to feel safe and calm, they need their own place. And so there need to be multiple types of housing to address the multiplicity that we are as humans.
I just want to follow up on that, but first and foremost, I'm an advocate, so I want to just take off the RQM hat and put on my human advocate hat for a second while I respond to that. Yes, I also recently heard Steinberg come and talk at a convention about this new housing thing, and I just want people to be mindful too that we are a small rural county, and what happens when these initiatives go out, or they're going to take money out of one pot and set it aside, is that it all breaks out into a percentage, and we get a percentage. So how much will the small rural county actually get? Will it be enough to make something work versus having those MHSA dollars come from the top? And I think we've seen that recently with, the county did respond to the SB 82 and for crisis respite, and the portion that we got was so small. It was 500 something thousand, I want to say, which, we can't build a crisis respite facility or crisis residential facility with this much money, but we need to take it and not give it, so we get kind of stuck into these things. So it's important to be, I guess, visionary with what's coming down the pike in terms of legislation and what we can apply for in grants and what funding we have now, so that we can kind of back ourselves up too, so that when these things happen, we're prepared to do something with it in the moment, be able to, versus we've been sitting on the MHSA housing money and sitting on the crisis residential, because the pot we get isn't enough to do something with immediately. So.
And that being the problem overriding mental health in every single area, there's not enough money.
Right.
This question is, if we're able to raise funds to build a hospital or use the old hospital, is there a plan to have money to run it?
So that's a great question, because that's the first thing that county people have asked me. Well, can your tax initiative be used as staff? And let me be very clear on this about, and I'm sitting next to 2 people who understand reimbursement, so please, I've been married a long time, I'm used to being wrong. If I make a mistake, let me know, okay?
We will.
But the mental health budget is right around $20 million a year. A little bit more, right around $20 million a year. And that money is not given to the county to say, go forth and do mental health work. That is reimbursable money. In other words, the county provides a service and they get reimbursed. So money out and money in is the way it works. And right now, our contracts are with Portner and Redwood Quality Management to provide these services. And so the services are being provided, the billing's being done, the money's coming back, and the services continue. So what I'm saying is, the only thing we're lacking is a location, because the services are being provided certainly here at some of our locations in Mendocino County, but in Yuba County and in Solano County, that's where the services are going and the money's going. So the answer is yes, in my simple-minded opinion. If we're spending $20 million now to provide these services, and a lot of it's out of county, then we're going to be able to get $20 million for the services we're providing, and it'll be in county. So whoever wrote that, if I'm wrong on my simplistic answer, please let me know. So, am I wrong?
They'll never invite me to come speak for RQM again. Well, you're not wrong. I just want to add brackets around some of that. So the way it works is not that we get handed $10 million if you're looking at splitting a $20 million contract. You're maybe handed 5, and then based on how much billing you do that goes up to the state and up to the feds, you get FFP, or federal financial participation, that gives you back 50%. So the county will give us 50%. We contract out $1, knowing that the other 50% is going to come back down from the feds. So where it may be 20 million, some of that is what is coming back from the feds back in versus 20 million divided in half and handed out. So it is up to the ASO with what you do with the money, because if you're not going to bill Medi-Cal and you're not going to bill those services, then you're not going to get it back down, and you're not going to be able to build your system, because there's also growth allocations and different things that grow based on how much you spend. So, if we don't bill any Medi-Cal, we get 5 million, we don't bill any Medi-Cal, we have 5 million. There's nothing else trickling back down in or helping grow those allocations so that we can provide more services the following year. So it is important to serve people with what they're entitled to receive and do that. So I just want to add that about the 20 million.
I would say also with that process, it takes time. So in any new endeavor, you've got startup money to fill the gap until that starts coming back. So that, what does that look like to set up and staff something, because you're not going to get that billable money back right away. You've got a time lag, both with the state and the feds. So I think some of those nuances is what we're going to have to look at when we actually get to the point where we're looking at the service.
And making sure that we're putting something out, if we are adding a psych facility here or a hospital, that it's something that can be used for the majority, because a freestanding psychiatric hospital is locked out of billing Medi-Cal on anybody 21 to 64. Yeah. So they're going to a psychiatric health facility, a PUF, or a med psych that is a hospital with a psych hospital attached. So you then get into all these different caveats of, yes, we want to put something here, but do we want to put something here where we're still going to have to send everybody with Medi-Cal that's 21 to 64 out of county, so.
And remember,
I would advocate for that.
The mental health reimbursement process is subject to audits by different organizations throughout the year. Basically at all times, there's some kind of audit going on.
Yeah.
And when an audit happens, of course, everybody says, oh my God, are we going to have to pay the money back? And then they'll pay the money back, and then there's an audit of the audit, and they'll pay the money back to Mendocino County. But it's my understanding of the $20 million which is spent for mental health, only $1 million comes from the general fund, and $19 million comes from reimbursements or the realignment and so forth from the state. And that's a direct question to the CEO that she told me.
Do you have a site chosen for the hospital?
We don't have a site chosen because, once you choose a site, you're hoping that the person's not going to obligate that, they're going to hold it. If the initiative doesn't pass, then they're going to say, well, what, are you still going to get it or what? The reason that we're doing it this way is because For the last 5 years, well, basically since 1999, when the psychiatric health facility closed, somebody from the sheriff's office, and I've been doing it since '06, is saying, why don't we have a PUF unit here? And the answer is money. So now the group that I'm associated with is working towards getting the money, and then after the money, at least after the initiative is passed this fall by 66% of the voters, then we'll be able to say, yes, we're not going to have to wait 5 years to collect the money to build it. We can start immediately. Once government gets a tax initiative going, that's capital. You can get loans against what's going to be coming in, and we're very comfortable with that.
Would you want that close to the jail?
Well, I want it to be as unassociated with a jail. I don't want it to be, a correctional facility / mental health facility. I think there's a few stigmas that might go along with that.
Sam.
Can you hear me?
Yes.
We can.
So I'm Sam Fernandez. I'm the Director of Behavioral Health for Mendocino Community Health Clinics. I want to thank everybody for coming. Taking care of our most vulnerable people is what we are here for, and I'm really grateful to everybody for their energy and efforts. We have the Little Lake Health Clinic. Maybe you're familiar with that. It's here in Willits. I think we serve something like 7,000 plus patients. Every human being needs a health home. Not everybody wants mental health services, but having a health home and giving the opportunity a place to get care is really essential. Unfortunately, there's some things that happen in Mendocino County that happen in other county, and that is you sort of get this split off between who's a mild and moderate in terms of need and who's in specialty. So you get these real challenges with trying to really take care of the whole person. Well, you got to go over there for that, but you can stay here for this. Even though you're a whole human being here, we're taking care of you for your diabetes and and your chronic pain and your many other conditions, your dental care, your care for her needs. So this is a really fragmented thing, and it's really unfortunate that we try to split human beings up into pieces and say, when you're really vulnerable, go over there, we'll take care of you here for these things. That's a real drag, really unfortunate. So we do provide what's called integrated behavioral health. So we do offer services to folks who need behavioral health services. So behavioral health, let's define that real quick. We think of that generally in terms of mental health and substance use disorder treatment. So when you think about behavioral health, that's generally what people are referring to, although we may be talking about something slightly different. That's generally what behavioral health, mental health and substance use. Tom made a really, really important point. That is around providing substance use treatment, but here's what's going to happen. We're expanding our substance use treatment in this county. That's coming, right? We just got a large grant to expand opioid addiction. Heroin and opioids, prescription drugs, are really a big problem. They create a lot of physical health problems, a lot of, unfortunately, other dependency, addiction, and other sometimes mental health problems. Mendocino County, we're the number 11 in number of suicides in the state of California. Lake County's number 1. Accidental overdoses, number 11, Mendocino County. Number 1, Lake County. So we have this tremendous problem. But as soon as we start treating substance use, guess what's going to happen? There goes mental health. Because so many people use substances to treat themselves for their mental health issues. So we start treating that, then we're going to actually need more mental health, more support services. I really applaud you guys, your agencies, everyone for all the work we're trying to do to come together. What part we play. We may be the larger health home for most of the folks we're talking about in Willits. I don't know. There's other providers too. In Ukiah, clearly, we're the largest provider of health home for folks. So the Medi-Cal population, largely, and we're the biggest health home. And so we really do want to find a way to treat everyone with all of their needs, and just remembering, though, that everybody has a right. Not everybody wants medicine. Not everybody wants to live somewhere else. That's not what they're looking for. So how do we sort of understand and respect that? And it's a big challenge. We want people to get care, but they may not be looking for the care that you think they need. Isn't that a tough one? Mm-hmm. It's really tough. And, a lot of us, Joy's here, and she's been in this county for many, many years, and others of you have, and I have, 30-some-odd years, and Tom, and, we have this historical knowledge of what the PUF unit was like. There's some big challenges to keep that going.
Sam, I want to ask you and the panel, because there's a topic that hasn't come up for me. As working at the community services, we get a lot of people coming in there and they melt down, you know, and we call, there's nowhere to go, you know. So some of what we're talking about today is seriously mentally ill, and okay, but what about those folks that need that service now? I mean, we can't get appointments for 4 to 6 weeks for people, and so what about the topic of, you know, urgent care for mental health? Okay, access.
Yeah.
Access, that's the topic that I would like to see a little bit explored.
I think one of the things, too, that wasn't mentioned in the 4 that Sheriff Ullman brought up earlier is crisis respite, where there's a short-term respite for stabilization when people they're coming in and they're symptomatic, like you said, and they don't meet 5150 requirements.
Do you want to
They
tell
don't
people
need-
what that is? Maybe people would like to know what that means. A 5150 criteria. Do you guys know what that means?
It is the code for if you're a danger to yourself, gravely disabled, or a danger to others, and at which point, if you're put on a 5150 hold, you meet criteria. There's very specific criteria, and you lose your rights temporarily. So for people who need a safe place to go for even a shorter period of time, they don't need a 2-week residential or a 6-month residential, but they need a respite. They just need a place to go to see if they can stabilize or if it's going to escalate. And then obviously the more trained the people are, hopefully they can de-escalate. Right now, Ortner's Access has 2 respite beds. I don't believe it's advertised, but we've had clients who really just needed a place to go for less than 23 hours, and they have 2 pull-out couch rooms at Access, and we've had people who were able to stabilize in that short period of time and not have to go to the hospital and could go home if they did have a home after that. And I think having that expanded where there's more respite possibilities would be very helpful. And also a mobile crisis team. We talked earlier that you have to go to the ER, and to get there 9.9 times out of 10, you're going with law enforcement. And if you have family that can take you, et cetera, that's wonderful. That's a nicer way to go. But you still are going to end up in the ER. It would be nice to have a crisis team that can go out to you. When my son he had several hospitalizations, it's nice to not even remember how long, like 8 or 9 years. But he had 3 hospitalizations through Mendocino County and 1 hospitalization when he was working with a family member in Washington, D.C. That was the best. They had a mobile crisis team that came to them. And he could voluntarily go for stabilization. And he was really, really sick. And they were able to get a team to their house, and they had never navigated. We were helping them long distance. And I said to myself, I want one of those. That I would rather have him in Washington, D.C., go into a crisis moment than here was a really sad moment for me as a mom and as a family member. But I said, I need one of those. Because I was on the phone and I could hear them. I could hear them with him. I could hear how they approached him. And he did not go on a 5150 hold. He went voluntarily. He was there for several days. And he got great care. Now, I don't know if that's, I don't live in Washington, D.C., so I don't know if that's the norm or if that was unusual. I can just tell you what my experience was. But that's where I said, I need those. I need them.
Thank you so much.
Can I respond to that?
Yeah,
also
of course.
For a second? So we would, on our side, I think there's a philosophical component of how you want to approach crisis. My viewpoint is if it's a crisis to them, it's a crisis to us. I don't need there to be a huge meltdown that's about to happen, and that there can be a pre-crisis stage where you're concerned about your safety or concerned about what might escalate to that, and we would happily see anybody and open them for 60 days. I think so I would say the crisis center is the answer to your question in terms of what to do with that person then, that doesn't need to go to the ER, that can then be cared for there and followed for the next 60 days while we're linking to something else and trying to avoid the ER.
Okay, you're suggesting that a call to the crisis center.
Well, it depends on how old they are now. I don't know that ICMS provides 60 days of aftercare.
But I mean, if there was a person, let's just say, what, 35?
Mm-hmm.
Okay, they were having a meltdown. Somebody calls you, and you could see that person immediately. That's what we're saying. I mean, I'm talking about access.
I could
here.
not.
No,
RQM could not if they are 35 after
who would?
July 1st. If the new era and we are doing adult crisis, then yes, that would be so.
Mm-hmm.
We would do the same that we are doing now on the youth side
But
in that fall.
access would be quicker than 4 to 6 weeks, is what we're saying.
Now, the access to getting a long-term provider going may still take the same. I mean, once a referral's in within 14 days, there needs to be an assessment. Then there's, them writing up the plan, getting them back in to sign it. Sometimes that can take a while. But services can also start through crisis immediately and then bridge that gap. So they don't need to wait 4 to 6 weeks. They can happen concurrently so that they can still be having a care manager and still have
That would be
a
good
therapist
news.
and have that
That would be
piece
good
going.
news. For sure.
And I come from another county. I moved here for this RFP and crisis process. I ran a mobile crisis team in Ventura County. And so I will say it's the norm. You could probably have one once you have a hospital in the county, because otherwise there's no, right now we have people, if they're waiting in the ER for days, that'd be us at their home for days. So I do think that's a potential bridge.
I actually, I've got 3 quick questions. Maybe the answers are not quick, but the questions are quick. Once again, I wanted to go back and just ask, how many living units do we need to take care of folks who need housing? Is there any kind of number?
Well, you also have, whether the housing is permanent housing or transitional housing in terms of what the turnover is. There also, I don't have an answer.
I don't either. I know that are you talking about housing for people with behavioral health, or are you talking about in general the housing need?
I think we're talking about behavioral health here today.
I can't hazard a number. I can look, when I look at the people that we serve, at any given time, even when we have people housed, like I have people right now who are housed, but they're going to lose their housing for a multiplicity of reasons. So there's a percentage of people, and I'd be happy, I don't have numbers right now, but I could go through our client lists and get percentages so that I'm not just anecdotal here. But at any given time, you have people that are at risk for losing their housing even when they have housing. So I count them when I look at the people that we serve because they're at risk. And then we're doubling up efforts, hoping to make a difference in their choices so that they don't make choices that put them in a position of losing their home.
You might find with the MHSA housing, they might have put in that RFP what the expected, what they believe the housing numbers are, and with the bid that they put out.
All right, good, thank you. Let me go to question 2. This is actually a question for Supervisor Woodhouse. Do you feel, Tom, would you support getting the Board of Supervisors to provide a couple $1 million to buy Howard Hospital if Howard were found that it would, meet the requirements for that kind of a facility? Because I know we've got 11 million in the county as a general reserve. I mean, could the county come up with $2 million for that, and where would we get it? What do you think?
Ask the next question, then I'll get up to speed.
My third question is for Chandra. It looks like you guys are setting yourselves up now to apply or ask to be given the adult contract for adult mental health services. Do you feel confident that you have the wherewithal, the people, the connections to provide that service? And can you elaborate? Or would you have to go through a period of big growth to make that happen? How close are you to being ready to do it?
You know, in terms of where it is now and the providers now, either being Manzanita or Hospitality or McCavan, none of that would change. You know, I believe ICMS is providing the access and crisis on the adult side and holding the FSP and the med management. So in terms of the system and looking what's out there, there wouldn't be much change in terms of who the providers are that are providing the service. I would imagine the change would be you would have more providers providing the service, either drawing in some of those youth providers, which doesn't also, I want to have a caveat, necessarily mean that they only want to provide services to youth or only do. I mean, we've had plenty of therapists that have come, you know, from Manzanita or from adult services. So, you know, there is crossover there between what people have a history of providing service for. Historically, the county was doing adult services before this contract with Ortner. So I think most of the providers, you know, that were at those organizations that were youth organizations out there doing that. I don't know. I can't speak to the, you know, willingness or readiness or urge to apply for the RFP as it's going forward. You know, I don't think it's about serving youth or serving adults. I think it's just about people getting served. And nothing drives me more crazy than hearing people not getting service that absolutely should be getting service, that are out there and needing help and not getting it. And I would say I am a huge fan of people getting the help that they need, getting the support that they need, and having it available when they need it, and knowing how to access it so that they don't have to call law enforcement or have to go to the ER, because they know what other services are out there, going to a crisis center or going to a crisis res or having respite. So I guess that I would say that on my own personal little soapbox perhaps, but you know, when the RFP, as it comes out and what the process is, I think it'll be a learning process no matter what it is. And I know that if it is in the best interest of our consumers and of the people in our county to get the service that they need, then I would guess that our QM would apply for that, knowing that that is ultimately what we want, is just people to get the help that they need.
I just wanted to make one comment, which is, in the short term, I'm more concerned about the transition. How do we get from Ortner being an ASO and successfully transition so that the clients don't feel this seismic upheaval of changing to another provider? And even though there are providers in place, you know, Manzanita and Hospitality, and I'm not representing Hospitality, but I work close enough to say confidently that we don't have capacity to meet the change. There would need to be hiring and more staffing to take on those that are cared for by ICMS if ICMS is not contracted with.
Is ICMS going to go away?
I don't know. I have no idea.
So,
ICMS is a nonprofit that was put into place and is an Ortner nonprofit, but it isn't Ortner management. I mean, I think it's important to note that, you know, what Chandra said earlier, that there was Redwood Children's Services that is Redwood Community Services now, and then there was administrative organization, Redwood Quality Management, that was put in place to do the management part of the system. Ortner is the management piece, but they have a nonprofit in place that does the services that Chandra just listed, the med management, full service partners, access crisis services, and some care management. And then as you go to the more people who need the most response, if you looked at the adult system of care right now, we were working towards where ICMS did the higher end crisis and full service partners, and then the care management of those most at risk, and then Manzanita and hospitality. And this is a generalized statement. We also have full service partners, and we have taken people who are more at risk. But in general, we were building a continuum of care. So ICMS is a nonprofit that has been established here and is doing those services.
While I understand their hesitation to committing to such an important question, Mike, I want to weigh in on this and tell you that I guess it's a confession. I was on the RFP team at the initial, in 2013, of going down this road. And I don't think that we could have predicted the problems that we've seen. I could tell you problems, and we would be here till midnight talking about problems. However, whenever we've had a problem, I'm talking about the sheriff's office or law enforcement, because the 3 chiefs of police, the district attorney, and I speak every month. We get together once a month, and the first half hour is to discuss mental health issues that have come up with our departments. I can tell you emphatically, I have never gone to Redwood Management, with a problem that hasn't been immediately addressed. And so while the 2 partners here are saying we don't know and so forth, I can understand that's what they're supposed to say. I have no doubt that if Redwood Management takes it, that we're going to see a good response. And a good example of this is, if you've been following the discussion with Ortner and the Board of Supervisors, one topic comes up: electronic medical records. Seems like a pretty innocent topic, okay? That's a very important topic when you're talking about reimbursements and you're talking about getting proper care, transferring a patient, and so forth. And Redwood Quality has electronic medical records. And it's a big difference between Ortner that says, we're working on it. So I don't see a problem. I sleep better knowing that that's the direction we're going.
And I would add to that in the beginning, if you remember way back, we did attempt shortly a combined crisis between Ortner and Redwood when we started, before we then separated off to do youth and adult. So we have done adult crisis and would have that also as experience, although not currently what we are doing, that we do have the providers that we have now and the people doing our crisis response were also with us in the beginning when we did do both adults. So if we do take it over, it is not a brand new thing in our wheelhouse either.
I jumped up when Tom said, I sleep better. Whatever he said after that, I don't remember. I want to tell you, since I was elected and really during the campaign, I do not sleep better. The number one issue that has driven me, and when I wake up in the middle of the night, wake up early in the morning, it's mental health and challenges. During the campaign, I was heavily supported by people who wanted me to do something about it, which is like go cure cancer or something. But I had an interest in it as a young person, mental health, wanted to get into the field, but I realized all the young people working on it were probably about as unstable as I was, and I needed to go find myself first. So I'm in my early 60s now, and I'm still looking, but ready to deal with mental health. I'm very optimistic. I want to make that clear right now. When I first was elected, the first week I was there, I went and spoke to the leadership, discussed the problems as I saw them, what we needed to do, where the responsibilities were, where the concerns were, and was pretty much very gently blown off and said, well, you'll figure it out. Give yourself time. So I want to thank the former employees and present employees and people, a number of supervisors and mental health people around the state. I go to all this training, and believe it or not, they all have challenges with mental health. And we're learning a lot from each other, and the employees have taken the time to educate me, and I would only guess I've spent 500 hours often during the middle of the night reading and studying and thinking about this. And people, if employees or even former employees who are working somewhere else are afraid to have their names identified to help a supervisor gather information, you can pretty much guarantee yourself there's something wrong with what we're doing. Any level of fear or control or denial tells you something's not healthy. So we've taken very bold, brave steps, and I understand the fear of the change we're going through. I'd feel the same way. I'm not afraid. I think we have made some steps, the beginning ones, that we have a chance now of making a major impact on this. And the timing is right, and that's why it happened, because the community was ready. There was a vote previously, maybe 5 months ago, where we could have voted to question and redo, I think it was the Ortner contract. I didn't vote for it. I didn't want to tip over the apple cart, and it wasn't the right time. We might have patched it and made some progress, but we wouldn't have reached the boiling point that we reached. Now we're making big changes, and I'm very proud of you all. Don't be afraid. When you're all working on something together, you really can't be stopped. What can stop us is fighting over things. So I'll address Margie's question so she can get up and chase me out of the room. The hospital is a fascinating option. And so if you said that was one of our 3 options, we don't have 2 other places where we could stick it or those neighborhoods would organize and not want it. The fear of this is like a food bank or even a church or a child babysitting nursery, daycare. I mean, we don't want anything near us that might bother us. But this subject is near us. I mean, why in the hell would we all be here unless it was near us and very important to us? We're going to have to deal with it, and there's going to be compromises. But ask Tom how many people have broken through his fence into the sheriff's office and stolen anything. Nobody's broken into that place, and we can protect Howard Memorial if that's what we choose to do too. It's not that hard. We're not in some wild country. I think it's a viable, reasonable option that we need to look at. There's earthquake challenges, but just here today you think about, what about some little mobile units in there as a puff unit or a cooling down thing for people? It would meet all the earthquake requirements and give people a place to relax. What I'm looking at still is all the statistics I got on these zip drives that finally I asked questions for 4.5 months. I had written questions into the leadership. Didn't scream at them, just asked every week or so how it was going. Finally got some lousy answers, but there's a zip drive in there that has all the services, the patients, the billing, broken down into lots of stuff. We're still breaking it down. But because we weren't giving good enough outpatient services, 5 years ago, we said, this is so bad, we have to do it, we have to outsource it, we have to get it out of here. This was the number we were at. 5 years from then, we're at 72.9% of that number that we said was totally unacceptable. So we're doing worse. So it was time for a change. What it translates to is about 23,000 services that we're giving less than we were giving when we were failing 5 years ago. That's 23,000 little things, maybe a phone call or med or appointment or whatever. But 23,000 of anything, you could change my life. If you all called me 2 times a piece, I'd do whatever you want just to get you to quit calling me, or I would change or lie to you. I'd do something. Numbers of services matter. That's a fact, not an emotion of, well, I think we're doing better. I think we're up to where we were. I think no, we're not. The facts is what you have to make decisions on. It's the same thing with the hospital site. Gather the facts, give the arguments both ways, have some debates about it, and deal with reality. It's not that hard to do. It's what we all do in our lives. What we can be stopped by is fighting, not listening to each other, letting the emotion rule the day, and not being courageous. And we're not going to do that this time. We can't afford to let the people get hurt any more than they already have. We're going to do something good. So I want to thank the courageous people who took the time to inform me, risked their jobs just by telling me the truth, not secrets about anybody's life, just the truth about what's going on. That's changed and going to change more. Right now, we are wasting and not going to reimburse more than $2 million a year because we're running the units so inefficiently. Our billing's all screwed up, and we're in total denial about it, and we're not drawing down all the money we can because we don't have the positions filled to get reimbursed 50 or 75%. We have 2 people maybe in quality assurance. That's where you run the numbers through all these systems and make sure you can get paid back and you're billing correctly. We need 4 more people. We need the same number other counties have, so that's one of my questions. What's it take to get these people hired? Because investing that money will get us more than $1 million back. We've chased away consistently anybody who stands up with new ideas and courage and challenges authority, even peacefully, are politely shown the door or unpolitely and sent to another county to work. We've dummied down and lost so many quality employees because we've allowed it to happen. We need to hire some more people and focus on this as something we're going to succeed at. It's not rocket science. It's the most complicated billing and all the names, and I've studied it and I only know 10% of it. It's horrifying, but it's simple. We can do it. I said the word we, I hope.
Yeah.
Kind of asking the question that was asked of you, kind of about will you talk to the...
Sure, that's the question. Another way of answering the question is we have volunteer fire department, we have the road situation, we have employees who aren't paid enough. I mean, we have enough to spend that $11 million. We could get it sluiced through there in about 2 meetings. But it's there as a reserve for when the economy crashes so we can get by for a few months. So we have to balance reality and compare these different priorities to each other. That's something government doesn't want to do. I don't want to say, no, we're not going to do the fire department, but yes, we'll do mental health. Then no, we're not going to fix your road, and yes, we'll do that. Politicians want to just push it down the road. But you need to come to the meetings, say what your priorities are, have the discussion, and make us have it.
Thanks. Thank you, Tom. Okay.
Hi, I'm Cindy. We do best in Mendocino County when we work on fixing things ourselves and help ourselves. I have an idea that I want to bring forward and get some meetings started on. Basically, we have land for all our homeless, low-income, disabled, and mental health patients. This is a county that's very giving. We could house our low-income seniors and disabled and mental health if we had low-income rentals for them. If we could put together something as a program that could be duplicated in other places in the state, where we worked with people who had land or who had a lot, put a small house on the lot, get money through HUD under the Housing First money, put that program to use where the owner of the property gets a benefit in taxes and they end up owning the property in 20 years. In the meantime, they have to rent it for no more than $30 or $300 a month, or whatever a low-income standard would be. So what we would be doing is putting low-income housing all over the place, not locked in just one spot. And we have people in this community that are giving and that would be more than happy to do that. It also, we have a lot of seniors that still own property, land poor. The little bit of extra income would help them. It's just a different enough Mendocino idea where if we got everybody working together on a pilot program like this, I think we could actually pull it off.
Thank you, Cindy.
I wasn't really going to say anything, but I feel like I have to say, be an advocate for the hospital, because it's a perfect place. And our whole mental health board has looked at it, and I think probably everyone on the board is for doing this if we can do it. And there are some issues with Oshpod, but I believe they can all be overcome, and we're working on that. But, you know, we need to do this for our mentally ill people. And ever since I've been a young woman, when my baby died, my parents wouldn't hear of me going to a psychiatrist because it was like a taint on the family name. Well, I found a way to go. But that's kind of how we look at mental health, is we want to sweep it under the rug. We don't want to deal with it. And the time is now to deal with it. And you know, I know maybe some of the neighbors are not happy, but those people are out there. They may be wandering the streets at night. They may be living in their backyard. And if you put in a facility that's locked up, at least you'll know where they are, and they'll be getting help, and they'll be getting medication. And I just think that as a society, we have a responsibility to treat our mental health patients just as we do our physically ill people. And so the hospital is perfect for this. You can have transitional housing there. Actually, I figured out you can have 5 separate addresses because you have to have a front door and a back door and a bathroom. And the way the hospital's configured with the Somali Center and the way it's put together, you can have 5 separate addresses. And you can have transitional housing there. They can go from being the 72 Crisis Center to the next step of transitional housing or temporary housing. So it can be done. I know it can be done. And it's up to us to convince the neighbors that, you know, it's not going to be dangerous, because it's already dangerous.
Thank you, Margie, very much.
So I've jokingly referred to mental health in Mendocino County as the weather. Everybody talks about it, no one does anything about it. And that's where we are right now. We've been talking about it. I'm not trying to criticize anybody who's providing the services, but the services that we're getting, you know, are the services we're paying for, and I'm saying we need to step up and do a little bit more. Because if there is any person in this county who thinks that mental illness has not affected them, themselves, their families, their neighbors, the employers, their employees, the people they shop with at the grocery store, I'm going to tell them that they're ignorant. They're not aware of how mental illness is affecting every portion, every segment of our society. And with all due respect to Mr. Woodhouse, he's still here? Okay. The Board of Supervisors often gets criticized for expenditures of money, whether it's a library tax, which was just changed, whether it's a retirement system that is in the front page of the paper. And so in the initiative that we're running, I just want to read you one quick paragraph. And it says, the funds approved for the revitalization of the above listed services shall be reviewed prior to the expenditure by a political independent oversight committee. The committee shall be comprised of a citizen selected by each member of the Board of Supervisors, a member of the Behavioral Health Advisory Board, the mental health director or his or her representative, the elected county auditor or his or her representative, the Mendocino County CEO or his or her representative, and a sheriff or his or her representative. The final member of this 11-person oversight committee shall be a representative from a Mendocino County chapter of the National Alliance on Mental Illness. So we're making sure that if we do get this passed and we do start collecting funds, we're going to have a political, independent group that's going to be aware of where every penny is going to.
Thank you, panelists and public. I want to take this opportunity to say that obviously this is not there's more to this than this one afternoon of discussion. So this is a beginning, and the planning group for the town hall wants to do a follow-up, and what that would entail, maybe that's people who are interested in this and can get together and move towards making things happen. I don't know. That depends on everybody here. But I want to thank everybody for their participation today. Thank you very much.
Thank you.